Join us tonight on the front lines of New York Med, where the fight to save lives is fought case by case. It all happens here in New York City, home to some of America's best hospitals, places off limits to cameras.
God damn it.
Until now.
We got a pulse. He's alive.
I want to be able to eat and go out and have more energy, and definitely want to be able to gain some weight back and put some more muscle on, because I definitely lost a lot of weight being sick. When I can eat whatever I want a big steak, I want a cheeseburger, I want some sushi.
Crohn's disease is an inflammatory disease of the intestine that gives people a lot of pain when they eat, and therefore a lot of weight loss and malnutrition over time.
I'm ready. I'm a little nervous now that I'm here, but it's all a step in the right direction. Facebook status. It's been a long wait, but the day is finally here. Only about an hour left, and I trust it all to a very charming Italian man.
Morning. Yeah, tell me, what do you eat?
I gotta tell you, I eat a lot of eggs. Scrambled eggs.
You don't mind if I don't join you for dinner?
Dr. Michelassi is not only the chief of surgery here, but he's a real world expert in gastrointestinal surgery.
So we gotta give you steaks and potatoes direct into your veins, so that you start the recovery now.
Well, I think that Jesse needs quality of life. Jesse needs the ability to eat. Jesse is 18 and he cannot go out and eat pizza with his friends with pepperoni.
How's it going? Good timing.
How you been?
I'm all right.
Did you gain any weight on the TPN?
2 pounds.
2 pounds?
Yeah, big old 2 pounds.
Jeez, man.
The operation we're doing today is a procedure that involves removing the inflamed and diseased portions of the intestine and then reconnecting those healthy segments.
He's looking forward to getting over this and living his life. But you have to be brave for him. You can't fall apart in front of him.
All right. Cue the music. There we go.
So what are you listening to?
Black Keys.
Oh,
He's told me that there's some sort of a hip new band, and I admit that I'm powerfully, profoundly uncool.
I'm gonna end up putting on Pink Floyd for when they start giving me the drugs.
now that's a band I know.
I have to go out to Comfortably Numb. That's how it goes.
We don't need no education.
A surgery like this, it's not like an appendectomy. It's not like the anatomy is known. It's not like what we find when we're going to go in is entirely understood.
Open the incision a little more. Very extensive disease. As we suspected and we have known for a long time, could I please have a 3 of silk?
The operation we're doing essentially involves removing the diseased portion of the intestine and sewing back together the healthy segments.
Whew. This is tough. So we have 20 different strictures.
A stricture is a narrowing or blockage in the intestinal tube.
This is going to be a long procedure. God knows what we're going to do.
Hopefully, Dr. Michelassi is going to go in there and repair as many strictures as he can and remove as little as he can get away with removing.
So we got to preserve as much as we can.
Every inch.
You know, all this scar tissue is because of the previous procedures. Knife to Dr. Tao, you cut my finger and your academic career is done.
Yeah.
Dr. Michelassi's words are, I'll see you in 3 years and you'll be 4 inches taller and 20 pounds heavier.
Okay, take him to a recovery room.
Yes, sir.
I'll go talk to the family. Can you imagine to be the parent of a 18-year-old and, you know, having your kid under surgery for 6 hours? So I'm going to make a drawing here. Today we really have achieved everything that we wanted to achieve without losing a lot of bowel. This is for him.
Do you know of a place where we can get it framed?
Can we get it signed?
Absolutely. Jesse will grow with time, will gain weight. I'm very happy that I was able to save all this much bowel.
I've gained some weight, actually grew an inch for the first time in a few years, and I have some energy. I'm feeling pretty good.
This has given him his life back.
When I first left the hospital, I emailed Dr. Michelassi and I told him that I had a big bowl of pasta as my first real meal.
Hi, I'm Fabrizio Michelassi. I'm a professor of surgery and the Louis Adbury Stimson Professor and Chairman of the Department of Surgery at Weill Cornell Medical College, New York Presbyterian Hospital. I'm really pleased to be here and tell you about what I do here at New York Presbyterian Hospital. I'm a gastrointestinal surgeon with expertise in gastrointestinal oncologic surgery, which means cancer of the colon, the rectum, the pancreas, the liver, the stomach, and expertise also in chronic inflammatory bowel disease of the intestine, which again means ulcerative colitis and Crohn's disease. Over my 30 years of experience, I've had the great pleasure of taking care of thousands of patients with Crohn's disease. And I've contributed to the understanding of the disease and what surgery can contribute to the same. Because of this experience that I've had the fortune of writing more than 200 papers in Crohn's disease. I've edited a book. I've prepared a movie for the diffusion of new techniques. And I've been able to talk nationally and internationally on the subject. Crohn's disease is a difficult disease for the patients. It's a disease that usually presents early in life. It's a disease that unfortunately we have new medications, but even the best medical treatment may not be able to take care of complications. It's a disease that once it has been taken care of medically and surgically recurs. So we know how difficult it is to live with this disease, and when patients come to me, the first thing I do, without any question, is to understand whether all possible medical treatments have been exhausted. If not, it's time to review the medical treatments and come up maybe with a new personalized treatment for the Crohn's disease for that particular patient. But if all optimal medical treatments have been exhausted, surgery can be life-saving, surgery can be life-changing. And surgery, nevertheless, needs to be done with some very important principles in mind. The first principle is that this is a recurrent disease. And so we need at surgery to save as much bowel as possible for these patients, because Crohn's may recur and the same patient may require additional surgery in the future. The second principle is nowadays we can do most of these procedures in a minimally invasive fashion, laparoscopically, to avoid major scars and also to facilitate the recovery from the surgery. And the third principle is that with modern treatments, we can certainly avoid, in the majority of the situations, to have to place stomas and ileostomies and colostomies in these patients. But let me go back to the fact that this is a recurrent disease and the importance, therefore, to maintain as much and save as much intestine as possible. About 30 years ago, new surgical techniques occurred and were devised. They're called strictureplasties. Strictureplasties are diseases for which you can take care of the strictures and the narrow points caused by Crohn's disease without having to resect intestine. And by doing so, therefore, sparing the entire length of the intestine or as much as possible. And about 15 years ago, I was proud to introduce a new strictureplasty, which at that point was called the side-to-side isoperistaltic strictureplasty, and since then has been referred to as the Michelassi strictureplasty for very advanced Crohn's disease with multiple strictures over a very long period of time. And so I think that nowadays the use of strictureplasties, when feasible, is able to decrease and limit the need for bowel resections in these patients. Well, studies have demonstrated that the majority of patients, and some studies have suggested that all patients sooner or later will require surgery for complications of Crohn's disease. So I think it's a safe bet to say that probably 70 to 80%, 85% of all Crohn's patients will require some surgery during their lifetime. Now, surgery is done for patients who are medical treatment, unfortunately, is not taking care of the complications of the Crohn's, and is done also for specific complications such as obstruction when the Crohn's disease closes down the intestine, or infections such as abscesses or sometimes fistulae, which are abnormal communications of the intestine with other organs. And fortunately, rarely, cancer or hemorrhage, which means bleeding. Well, there are many new advances in the treatment of Crohn's disease, both in the medical treatment as well as the surgical treatment arena. If we concentrate just to the surgical treatment arena, I think that the two main advances have been the introduction of bowel sparing procedures as well as laparoscopy, minimal invasive surgery. Now, this is a disease that unfortunately is recurrent, and even when it is removed completely surgically, chances are that eventually, sooner or later, it'll come back again and may require additional surgical procedures. In view of several procedures required in a lifetime, if these procedures are all based on resecting intestine, the end point is going to be a short intestine, a shortcut. And so about 30 years ago, surgeons came up with the idea of strictoplasties. Strictoplasties are bowel-saving procedures, which means that the complications of Crohn's disease, especially the obstructive complications, the narrow points that Crohn's disease can create in the intestine, are taken care of with a procedure that is not based on resecting the intestine, but actually making it larger. These are strictoplasties. And over the course of 30 years, many strictoplasties have been described. And actually 15 years ago, I produced a strictoplasty that at that time was called the side-to-side isoperistaltic strictoplasty, and since then now is referred as the Michelassi strictoplasty, for extensive Crohn's disease of the small bowel and severe Crohn's disease of the small bowel. The other advance, I said, is minimal invasive approaches. Nowadays, most surgical procedures can be done with laparoscopy through very small incisions to the advantage of the patient. First of all, a smaller incision, a more cosmetically pleasing result, and most importantly, a faster recovery. Well, actually, things have changed dramatically in the last 10-15 years. Patients used to stay in the hospital a week or two after even the simplest procedure for Crohn's disease. But now, due to the advances with minimal invasive surgery, due to some changes in the treatment of these patients, such as avoidance of the nasogastric tube, a plastic tube that we used to put from the nose down in the stomach, patients recover much faster, and the average length of stay after an abdominal procedure for Crohn's disease is 4 to 5 days. Well, unfortunately, we still do not know what causes Crohn's disease nowadays. There are several theories, and some of them have been substantiated by practice and by data. We know for sure that 10% of patients, at least 10% of patients, have a genetic predisposition to Crohn's disease. Other theories also suggest that the environmental agents have a role in it. Some also suggest that infections and therefore microbiological agents have a role into the inception of Crohn's disease. And finally, other theories ascribe a different immunological defense of an individual to be at the basis of Crohn's disease. Whatever it is, it's pretty clear at this point that this is a multifactorial etiology, and therefore still escaping a clear and simple explanation for the Crohn's disease. Now, over the past 50 years, but certainly over the recent 10-15, a lot of advances have been achieved, both in the medical treatment as well as the surgical treatment. And in the medical treatment, nowadays, past are the times when Crohn's disease was treated just with steroids, and the introduction of biologicals have really changed the history of the disease, the natural history of the disease. And surgically, the advances of laparoscopic and bowel-sparing procedures have been equally important. Both the gastroenterologists and the surgeons contribute tremendously to the care of the patients with Crohn's disease, aided by the radiologist and the pathologist when necessary. It is nowadays a disease that cannot be cured as yet. It is a disease that is recurrent, but I think that in the appropriate hands of a very expert gastroenterologist and a skillful surgeon, the Crohn's disease complications can be taken care of, maintaining in mind the quality of life of the patient and the ability of recovering from the disease and from the medical treatment and surgical treatment with the least possible complications. Yeah, the first side-to-side isoperistaltic stricturoplasty that I performed was in 1993. And I did not publish the results until 1996 because I wanted to perform a few and make sure that indeed the procedure was safe and reproducible. Then, with time, I collected my own experience, and by 2000, I presented a series with a large number of side-to-side stricturoplasties, followed for several years to indeed make sure that the beneficial effects of this stricturoplasty were lasting over the post-operative course and over several years. That paper, really published in 2000, made the community of surgeons aware of this new stricturoplasty. And since then, this stricturoplasty has been adopted by many surgeons with large inflammatory bowel disease and Crohn's disease practices around the world. And it's probably safe to say, although nobody really has precise numbers, that at this point hundreds of side-to-side stricturoplasty procedures have been performed around the world by many different surgeons. Well, traditional stricturoplasties such as the Haneke-Mikulik stricturoplasty or the Finnish stricturoplasties are well suited to narrow and short strictures. And they can be indeed performed for multiple strictures, but when a patient presents with severe and extensive strictures over a long length of intestine, such as a foot or 2 or 3 feet, the side-to-side stricturoplasty is better suited for these patients, while the traditional Haneke-Mikulik or Finnish stricturoplasty would be really not particularly good at addressing this particular disposition of strictures. So it's very important that a surgeon be extremely familiar with all kinds of stricturoplasties and all kinds of bowel-saving procedures, because it is not until the time of surgery that you can really decide which one is the best fit for that particular patient. And in many times is a Haneke-Mikulik stricturoplasty, sometimes is a Finnish stricturoplasty, but in some severe and extensive Crohn's disease, the surgeon may be called to perform a side-to-side isoperistaltic stricturoplasty. Well, it really depends on many factors, on the work that you do. If it's a heavy physical work or is a desk job, that makes a big difference. Also, it all depends on the amount of recuperation that you have to do, not only from the surgery, but also from the condition itself. Sometimes Crohn's disease is so debilitating, the patients come to surgery already quite debilitated, and they have to recover not only from the surgery itself, but also from the debilitation before the surgery. But taking in consideration all this, I think that patients usually can return to work about 10 to 14 days after discharge from the hospital, and sometimes may take 3 or 4 weeks if there is some recovery to be done, as I said before, from the debilitating effect of Crohn's disease, which have taken place even before the surgery itself. But in general, I would say that it's a safe bet to say that everybody can return to work between 10 and 21 days after discharge from the surgery.